So certain international standards have been set to provide guidance and assistance to anesthesia professionals. Professional societies, hospital and facility administrators and governments for improving and maintaining the quality and safety of anesthesia care. So this is the first thing. They were adopted by WFSA on 13th June 1992 and revisions were ratified on 5th March 2008 and 19th March 2010. Adopting the standardized language of the World Health Organization minimum standards that would be expected in all anesthesia care for elective surgical procedures, they are termed as highly recommended, which is otherwise functional equivalent of mandatory standards. These should be definitely present. These highly recommended standards are applicable throughout any elective procedure from patient evaluation until recovery. So we have these mandatory things which have to be followed right from the pre-op assessment to complete post-op care. However, immediate life-saving emergency measures are always taken in a precedence in emergency. So if it is an emergency surgery, then we cannot insist on all these mandatory things to happen. So there it is more important on time basis to save the patient rather than sticking to these rules and trying to follow them. Now, International Standards of Safe Practice 2010, what are all the general standards? The professional status. Any anesthesia service is a vital component of basic healthcare requiring appropriate resources. Then professional organizations. Anesthesia professionals should be from appropriate organizations at local, regional or national settings of standard practice. Supervision of training and continuing education, continuing professional development with appropriate certification and accreditation. So the person who is going to give anesthesia should be properly trained and should have a proper certification and general promotion of anesthesia as an independent professional specialty. So he must be a specialist anesthetist all the time. But in USA they have what is called nurse anesthetists for lack of hands of trained qualified anesthetists. But they are equally competent and they are supervised by these qualified people. So that is accepted. And training, certification and accreditation, these patients, anesthetists who provide anesthesia should have had adequate time in training and both initial and continuing training should be there and adequate standard of knowledge, expertise and practice is attained and maintained. Then record and statistics, record details of each anesthetist should be made and preserved with the patient medical record. And peer review and incident reporting, institutional and regional and national mechanisms to provide continuing review of anesthesia practice should be instituted. Regular confidential discussion of appropriate topics and cases with multidisciplinary professional colleagues should take place. This will help to improve your day-to-day practice and avoid any mistakes or rectify any mistakes that have happened. And protocols should be developed to ensure that deficiencies of individual and collective practice are identified and rectified. And workload. Sufficient number of people should be there so that there is no physical fatigue or overwork so that the concentration lapse will happen. Coming to the personnel, anesthesia professionals should be dedicated to each patient. That is one patient, one anesthetist. That should be the category. But sometimes if it is a monitored anesthesia care or sedation, then we can look after 2 or 3 patients at a time and should be responsible for the transport of the patient to post-anesthesia recovery facility and the appropriate trained personnel should go along with that. And an anesthesia professional should retain overall responsibility of the patient during recovery also. And these patients have handover protocol is very, very important, especially when you do a major case. Handing over from the theater to the PACOC should have a proper set protocol so that all the vitals are checked before seeing the patient. There have been instances where patients, the theater anesthetist will say, when I transferred the patient was alert, talking, fully conscious and having a normal vitals, and soon in the post-op ward, you get a call that patient's pulse is not felt and patient is not responding. So that sort of situations have happened. So there should be a standard protocol to make sure that you can find out where exactly the mistake has happened, whether it is in transportation or whether after receiving the PSCO. All these things can be identified only by having a standard protocol. And anesthesia professionals should ensure that direct care is delegated during after an anesthetic. The person to whom responsibility is delegated is both suitably qualified and conversant with relevant information regarding anesthesia and patient. Then coming to the facilities, equipment and medications, as we said, all these things should be regularly available and we should be checking them and making sure that the equipments are in working condition. And the use of checklist is very, very important and highly recommended. And pre-anesthesia care and monitoring standards starts with the pre-anesthetic care. So patient must be evaluated by anesthetic professionals prior to administration of anesthesia, and an appropriate anesthetic plan should be formulated, and patient should be informed and consent should be obtained, and must ensure that all necessary equipments are present and functions correctly before we start the case. And anesthesia professionals should ensure that assistance is available when needed, and they should have been properly inspected. And pre-anesthesia check is a very important checklist to be followed and established in each healthcare institution providing anesthesia services. The anesthesia system and anesthesia localization should be executed to each anesthetic. And many hospitals will have a pre-anesthetic checklist form like this. All of you would be having some sort of. So each one may be slightly different, but majority will be with regard to the airway, the comorbidities, and the simple mnemonic that you can remember to ask in even in emergency is the AMPLE, AMPLE. A stands for anesthetic, M stands for medication, P stands for previous, A for allergies, M for medication, P for previous surgery, L for last meal, E for emergency leading to the situation. That is that same mnemonic will be useful even in an elective case if you have to do a quick survey of the patient. And monitoring during anesthesia, there is very, very essential oxygenation should be ensured at all times, and recommended that you can monitor the highly recommended is all the time oxygen should be available during general anesthesia. And the next step recommended is if you can measure the inspired oxygen concentration, that will be well and good. And low oxygen concentration alarm should also be available. The oxygen supply failure alarm also should be there in the machine. These are all recommendations. And systems with interlock to prevent misconnection of gases is also recommended. That is, this should be available. And oxygenation of the patient, tissue oxygen should be monitored continuously for visual examination as well as adequate exposure. Continuous use of pulse oximetry is highly recommended. Coming to airway and ventilation, adequacy of airway and ventilation should be continuously monitored, and breathing circuit reservoir bag should be observed, and disconnection alarm should be there, and continuous measurement of inspiratory and expiratory gases is suggested. So even if you don't have inhale exhale gases monitoring, it is better that if you have that. So it is only a suggestion, it is not a must. And coming to circulation, you have to measure. Highly recommended is you always have a pulse by monitoring display of the pulse oximeter. And what are all the recommended is an ECG. So ECG is not a must for every case. It is only a recommended guideline. And defibrillator also should be available in the theater, which is also a recommendation. And coming to the tissue perfusion, of course, continuous monitoring of capnography and pulse oximetry, temperature, all these things are recommendations. And neuromuscular function. So using a nerve stimulator is a recommendation. Depth of anesthesia monitoring is only a suggestion. It is not that it should be always available, and the application of electronic devices and audible signs, signals and alarms which are there should be able to function correctly, and it should be activated and kept. It should not be silenced. And post anesthesia care facilities and personnel all should be uh, available. Coming to monitoring in the post anesthesia care, they must be observed and monitored in a manner appropriate for the vital functions and medical conditions. And pulse oximetry is a mandatory thing, highly recommended until the patient's consciousness is relieved. And pain relief is also very, very important. So all these things are the recommendations are based on which we have to function this to provide a safe anesthesia. Okay. And of course, what you mentioned about the airway equipment, their functionality, the drugs, mismatch, making mistake with the wrong drug administration, all this also can be mentioned as a part of safe anesthesia. And preventing theatre pollution by the gases exhaling out, which are prevented by proper scavenging or total intravenous anesthesia. All these are also proper recommendations that we have to follow. Okay.
Okay, sir. Thank you.